Work of breathing is an intangible sign of impending respiratory failure. So if your patient has a saturation of 98% and his ABE look reasonably respectable, you may be relaxed. But the trap is that patients don't die from low oxygen first. They crash from high work of breathing. The work of breathing is the energy required to overcome the lung elastance and the airway resistance. So when work of breathing increases, increased respiratory muscle oxygen consumption happens, increased negative intrathoracic pressure happens, increased transpulmonary pressure happens. This leads on to dangerous patient self-inflicted lung injury, diaphragmatic fatigue, and sudden respiratory collapse. So a patient can maintain normal SpO2 while he is silently exhausting and going for impending collapse. The Florali trial published in NEJM showed that in acute hypoxic respiratory failure, high flow nasal oxygen reduced intubation rates in selected patients. But the deeper insight from the subsequent analysis showed that patients with persistently high respiratory drive had worse outcomes despite oxygen support. So a patient with normal oxygen saturation but tachypnea and accessory muscles acting is at high risk of sudden decompensation. Also, large swings in esophageal pressure to the tune of 10 to 15 centimeters of water correlate with lung injury even when ventilatory settings are protective. This is a frequently missed thing in routine ICU monitoring. So don't just look at the numbers, don't just look at the waveforms, look at the patient. Bedside red flags of high work of breathing are using accessory muscles of respiration, suprasternal and intercostal retractions, respiratory rates above 30 per minute, and paradoxical breathing. So the practical thing would be if work of breathing is high, support early by NIV, HFNC, or even intubation. Don't wait for saturations to fall. So in respiratory failure, oxygen can mislead. Work of breathing tells you the truth and prophesies the future.